Over 16 years ago, we experienced what no parent should experience, which is the loss of a child.
Our daughter, Rebecca Ava, was born July 13, 2006. After she was home for a short bit, she had some alarming symptoms, so we rushed to the ER. And when we got there, we were met with doctors that made us feel that we were being neurotic and overprotective, and she will be fine. And you want to believe them. So we brought her home. And unfortunately, the next morning, she was bleeding from the nose, and my husband had to do CPR. Then we rushed back to the ER, and that's when she was pronounced dead. After she passed away, we learned from an autopsy that she had enteroviral infection. When we started talking to pediatric experts, we learned that ERs aren't all prepared for children, and the entire EMS system, even from the 911 call, it's not set up for children. There's no required ongoing training of pediatrics in ERs. 1 in 5 children go to the ER every year. It's life or death where you take your child, and it shouldn't be that way. But this is preventative. You have a 30% lower risk of your child dying if you take them to a higher pediatric-ready ER.
There was a lot of pain and anguish, and we decided we wanted to make a change to improve healthcare for children, that no parent has to experience what we experienced firsthand. Through a lot of research, hard work, tears, and friends and family and people in the broader community, we were able to start the foundation and really make an impactful change.
Our charity has done great work and has improved training and healthcare for children. 90% of the money raised goes directly to the cause and directly to impacting children's healthcare. We've gotten into over 1,200 hospitals. We train the entire medical staff. We train doctors, nurses, even administrators. We train everyone in the ER setting. I believe that our work has been life-saving, but we've been a Band-Aid. It's a national crisis. I don't think people get that yet.
It's not fair that you don't have the basic needs to meet those children.
To get the appropriate training, supplies, and equipment in every ER for every child is cost efficient. So there's no reason that we shouldn't be helping our sickest, most vulnerable children. We need to band together, all parents and caregivers, to make sure and prevent that tragedies don't happen to other families. So it's time for these regulatory and government agencies to make it happen, and we need to hold them accountable. We actually have a petition on ourbabyfoundation.org to change the emergency medical systems for children throughout America. So our next step is doing this media roundtable so we can get the experts, parents and caregivers together to talk about the need to really make a system-wide change for all pediatric emergency systems in America. Some of the latest research to come out in the last few years ties mortality to pediatric readiness in ERs.
I firmly believe that if Rebecca was seen by pediatric trained doctors, there is no question in my mind, based on thousands of hours of research over the last 17 years, that she would be alive.
We believe that no matter where you take your child, at any ER in America, that they should have their best chance of survival. Nothing I ever do will bring back my daughter, but our pain and our grief is so deep that I don't want any other family to feel this way. And I do believe that the changes necessary to prevent this are attainable, achievable, and are so close to happening, and that's why I keep going.
Thank you so much for taking the time to join us for this critical conversation around pediatric emergency healthcare readiness. As you just saw from the video, there is a national crisis when it comes to pediatric emergency readiness, and our children are paying the price. My daughter Rebecca and our family story is a testament to these shortfalls in our EMS system, and we need to do better for all of our kids and all of our future families. These issues are real. The situation is dire, and we hope to break the silence and create positive change through conversation today. Science has shown that EMS systems designed for adults cannot save the lives of children. Our country must adapt our EMS systems to the unique needs of children. To be totally transparent, the medical community is aware of these issues, but many parents, caregivers, and the press are surprisingly not, which is the impetus for today's roundtable. By the end of this roundtable, we are hoping you agree that if we can possibly save approximately 1,500 children a year with cost-efficient, proven solutions to improve pediatric emergency readiness, why wouldn't we make this change as soon as possible? I would like to thank our 6 roundtable participants and for all our guests today who understand how important it is to put our children first. I also thank my husband, Andrew, who has worked tirelessly as my partner for 17 years for all of our baby's efforts. I would like to thank the media who is here today and who has taken the time to listen, ask questions, help spread the message and awareness to create change and save lives. You are about to hear from 6 of our top experts in the field of pediatric. Each of these experts bring a unique perspective and a wealth of knowledge to the conversation. And I'm eager to provide all of you tuning in with a comprehensive understanding of the challenges at hand, and most importantly, the solutions that can lead to positive change. After we hear from our experts, we will move to a question and answer time period. So please feel free to submit any questions at any time via the question icon on the right side of our chat, and our experts will respond accordingly during our Q&A time. So I'm going to start off by letting our experts have the opportunity to introduce themselves. Dr. Remick, can you start us off?
Thank you so much. I'm excited to be here today. My name is Kate Remick. I am based out of Austin, Texas. I'm both a pediatric emergency medicine and EMS physician, and I serve as co-director for the National Pediatric Readiness Project.
Hi, I'm Dr. Richard Flyer, a retired community-based general pediatrician and an active child advocate. And I consider this to be an absolutely historic event because the world, as well as the United States, is going to hear about this tragedy that we have and is going to hear about how we can fix it. So thank you.
Dr. Auerbach, would you like to introduce yourself?
Oh, yeah, sorry. Dr. Mark Auerbach. I am a pediatric emergency physician here at Yale and have been a longtime collaborator with the Rabinowitzes on simulation-based education programs to collaborate with community EDs in improving pediatric emergency care. And I also serve a number of roles with the EIIC, the federal group that Dr. Remick mentioned.
Hello, I'm Dr. Carlos Camargo. I'm a professor of emergency medicine at Massachusetts General Hospital and Harvard Medical School, and I'm also the founder and ongoing leader of the Emergency Medicine Network, or EMNET. Thank you, Phyllis, for putting this together, and you and our baby have just done such a terrific job. We're all so grateful.
Hi, I'm Bill Linders. Thanks for having me here. I'm a father of 4, 3 girls and a boy from Connecticut. I work at Middlesex Health as an emergency room attending, and I'm a pediatric emergency care coordinator.
Thank you all for those introductions, and Dr. Nick Cardney from CHOP will be joining us shortly. So I'm going to start off this roundtable with Dr. Remick. I'm going to ask you a couple questions, and feel free to speak freely. Can you start by speaking to some of the staggering statistics that the public should be aware of as the progress in this field concerning emergency medical services for children? And secondly, what are the costs associated with hospitals and EMS systems to fulfill these requirements to become pediatric ready?
Thank you so much for that question. And just before I begin, I am a co-director for the Emergency Medical Services for Children Innovation and Improvement Center, but I'm not speaking on behalf of the federal program. I also, in this role, as I mentioned, serve as co-director for the National Pediatric Readiness Project. What we know is that in the United States, about 20% of children seek emergency care every year. And when that medical emergency occurs, it's really critical that they have access to high quality emergency care that's close by, ideally within 30 minutes. And The challenge that we're facing currently is that not every emergency department is designed to meet the needs of children. In fact, today in 2024, there are no universal licensing or accreditation requirements that call out the specific needs of children. Additionally, there is no specific signage that helps families to navigate our emergency care system to identify which emergency departments are most ready to meet their needs and provide the highest quality of care. I say this, however, knowing that as a clinician myself and as an emergency care provider, that every clinician and caregiver working in a hospital wants to provide the best care possible to every patient, and probably none more so than the pediatric population. And this is really demonstrated by the high level of engagement that we've seen in the National Pediatric Readiness Project. This has been an ongoing effort over the last few decades, and really began with a national comprehensive assessment of our emergency care systems to meet the needs of children. And we've seen over the last couple decades significant engagement in this effort. Over 4,000 hospitals participated in 2013, and even during the COVID pandemic, we had 71% of the 5,000 hospitals in the United States participate in this effort. And this assessment and this National Pediatric Readiness Project really helps us to identify and ensure that the resources are available to children in emergency departments. So the National Pediatric Readiness Project started about 3 decades ago. It is a collaborative effort between the American Academy of Pediatrics, the American College of Emergency Physicians, the Emergency Nurses Association, and the Federal EMS for Children program. And these organizations have been working collaboratively, and I would say alongside the work that Phyllis Rabinowitz, Our Baby, and other organizations have done. But really, these organizations have come together through a national quality improvement effort to improve the capabilities of our pediatric emergency care systems. And this is really an effort that's known as the National Pediatric Readiness Project. And because of the high level of engagement of frontline healthcare providers, there's a lot that we now know about the state of our emergency care systems to meet the needs of children. First, we know that over 80% of children are seen in non-children's hospitals. And this is important because most families, most individuals who work in the field know that there are children's hospitals, and they believe, well, that must be where children go. But collectively, the majority of children don't go to children's hospitals. We also know that the majority of EDs, about 70% of emergency departments, see fewer than 10 children per day, meaning that the exposure that every ED has to the most critical or injured child is relatively infrequent. We also know that over 90% of children have access to emergency departments, which is great. However, over 90% of those children live closer to a non-pediatric ready emergency department than one that is indeed pediatric ready. And again, as I mentioned, it's difficult for families to navigate and know exactly where to go. Because of the National Pediatric Readiness Project and the work, we know that there is a 60% decrease in mortality for injured children who are seen in pediatric ready centers. And we know that there is a 76% decrease in mortality for ill children who are seen in pediatric ready emergency departments. And this is just astounding, especially when we know that less than 1% of children actually die in the state of an acute emergency. And so to see that degree of difference is really important to recognize. We also know from the National Pediatric Readiness Project work that when a child unfortunately does succumb to their illness or injury, that the median time to death is only about 3 hours. And that means that there's simply not enough time to transfer that child to another center, and why every emergency department must be ready to immediately stabilize and resuscitate a child if the case may be. And then most recently, we've seen that there's as much as a 3-fold decrease in disparities because of pediatric readiness, and I think there'll be some further discussion about that. As mentioned in the video that you all just saw, the median pediatric readiness score across the United States is 69.5. And if all emergency departments were pediatric ready, we know that it is indeed cost effective. And in fact, the average estimated cost would be between $4 and $48 per pediatric patient visit. And so the gaps that we've identified in these national assessments have resulted in a tremendous number of efforts, both at the national, state, and local levels, from the development of educational tools and resources, national quality collaboratives, evidence-based practice guidelines, policy safety recommendations, the establishment of quality measures and systems performance measures. We've also done a tremendous amount of work when it comes to workforce development and how we can integrate pediatric readiness efforts into organizational goals. But despite all these efforts over the last several decades, there's still a tremendous amount of work to be done. Well,
Any final thoughts? We're going to come back to you. Any final thoughts around the statistics?
just, what we have seen from the National Pediatric Readiness Project is that there are some very clear drivers of pediatric readiness. One of those is having an individual at every emergency department called a pediatric emergency care coordinator, really someone who is championing the needs of children in that emergency department, someone who's overseeing and ensuring that the policies, procedures, and protocols and those sorts of things are in place, engaging in quality improvement. And then lastly, and most recently, we know that verification programs or recognition programs play a significant role in ensuring everyday readiness to meet the needs of children. Thank you so much.
Thank you for all that information. And it's great to hear that there are cost-efficient solutions that are available to make these emergency rooms ready. So Dr. Flyer, we're going to move on to you. And I want to say that you have trained in some of the finest children's hospitals, but you spent your career working in community hospitals. For over 40 years, you recognized medical services were underprepared for patients. Can you tell us about your 40-year experience? Now, I know that we have made some progress in that time for pediatric emergency care, but please help us understand why we must adapt our EMS systems to the unique needs of kids in a more complete, bigger way.
Thank you, Phyllis, for the chance to speak. I want to thank you and our baby, because this is, as I said, an historic event. And just briefly, I'd like to thank my wife, Julie, who's helped me for the last 40 years. So today, I sort of feel like I'm a pediatrician with 80 million patients. That's just in the United States. A couple billion more worldwide. So the issue we're addressing is for all of them. I'd like to just start by saying that if you want to save a dying child, you have to have a team with 6 rights. You got to be in the right place, have the right help, at the right time. You have to have the right people with the right training and the right equipment. And we don't have that yet. I'd like to try to make Dr. Remick's statistics a little more understandable simply by relating how it is that I come to this whole issue. As a medical student at Harvard, I knew I wanted to take care of kids. And I sort of knew I didn't want to be a professor. I wanted to go out in the world and take care of kids. So I did something that was sort of unusual for someone at Harvard. I chose to go to the Bronx, New York, to a big municipal hospital, the Jacobi Hospital, Einstein, because I knew there I would learn about how to take care of the sickest kids. And it turns out I did. I learned to become part of a team. I emphasize that because one person cannot save a dying child. You need a team, and it has to be very well organized. So if I can just take you into the Jacobi Hospital emergency department for a second. A child is brought in by EMTs, paramedics, is first wheeled through the adult emergency department, and then gets to the emergency department for kids. And the team converges on the child. There were special parts of the room where everything was ready. We had the breathing tubes, we had the medications ready in appropriate doses, anything that we needed, the correct size intravenous needles, it was all there. And there was a team of children's doctors and children's nurses. And the most experienced person in the room led the effort to save this dying child. And the rest of us in the beginning were assigned different tasks until you reach the point in your training where, you know how to do it, and you start running everything. At that point, you know how to keep a child alive long enough to get them upstairs at Jacobi into the pediatric intensive care unit. And you continue your training and you learn how to take care of them in the unit. And then you finish and you go out into the world, as I did. My wife and I went back to our hometown and we started a pediatric practice from scratch. And within days, I was being called down to my community hospital emergency department for kids who were really sick. And I'd rush down there in my car and I'd go into the room where the child was. And to my utter astonishment, I realized I wasn't in the pediatric emergency department at Jacobi. I was 20 miles away in an adult emergency department where people were struggling to do the right thing. So many times I left frustrated and defeated. I would go back to my practice and try to recuperate in my office. And then in my office, there were times when people, not knowing that they should have sought help by calling 911, would come in with a child who was dying. And I had to call 911. So I got to experience what it's like when the first responders arrive. And there was one time where I looked at the child and I knew that the child had meningitis. And the first responders were like, well, what do we do now? And I just said to them, we got to get this kid right away to a hospital that's not the nearest hospital, but one about 5 miles away that was like Jacobi Hospital. And we got a chance at saving this kid's life. So I'd like to say that this stress and that I felt and that everyone was enduring around me trying to help the kid, it led me to say there's got to be a law. There's got to be a way to change this. And in 1992,
we're going to get to that.
I know we're going to get to that, but I just want to say we did pass the first law in the country to do this. That did not get implemented. And every night that I was on call for the 35 years I was in my community, I never once went to sleep without worrying that I was going to get a call about a kid who was dying, because I knew there was no system to save that child. And yes, I do want to address the solutions later in this.
No, but that was a very good explanation of, because you always talk about how the pediatric ERs are like ballets and they all work well together and everyone, really wants to do the right thing in these adult ERs, but it's just the system that isn't working.
No,
for
we haven't organized it.
It's not personal. It's the system. So
yep, there's no system.
Yes, and your 40 years of experience, you probably have many, many, many stories. So thank you for sharing.
Absolutely.
I'm going to move to Dr. Auerbach next, who I probably have known the longest on this roundtable. Can you start by telling us, for parents who may not be as knowledgeable or close to these issues, they may not know what questions to ask or what signs to look for hospitals' pediatric readiness? Like, how can they advocate and look out for their children within the current system? And then can you also address challenges that you've observed in maintaining sustainable improvements over time and why non-children's hospitals haven't progressed? Like, are there more initiatives that we can be doing to accelerate this progress? Like perhaps your impacts program?
Excellent. Thank you so much, Phyllis. And thank you, Dr. Flyer and Dr. Remick, for those wonderful comments and context. In terms of what parents can do and what we can do as healthcare providers, I think the concept of the pediatric emergency care coordinator and a person who is taking accountability and responsibility for pediatrics in every emergency department is really a foundational piece to this work. And I would say, going out to hundreds, if not thousands of EDs across the country over my only 15 years of experience, Dr. Flyer, not 40, I have yet to find an ED where there are not people in that ED that are passionate about taking the best care for children. And I just want to flag that actually in the United States, I see we have some international colleagues on the call, there is no such thing as an adult emergency physician or an adult emergency department. Every ED in our country can take care of children and will have children present to their ED with many of those EDs, it may be a very low frequency occurrence. As Dr. Remick mentioned, many EDs see very few patients per day. Actually, in the most recent pediatric ready data, 50% of EDs, and it's sort of astounding to hear this, care for less than 5 children per day, oftentimes only 2 to 3 children. And the frequency of a critically ill child may be once every months or once every year's frequency. And this is where some of the programs that Phyllis is mentioning, leveraging on-demand training and systems assessment events through something called simulation and the use of planned events of pediatric ill and injured children coming to these departments to not tell them what they don't know or throw them under the bus, so to speak, but to actually have a lived experience where you can talk about what it would be like to take care of an acutely ill or injured child. Are you ready to take care of their child? Do you have a pediatric champion or pediatric emergency care coordinator who can, after that simulation, take some accountability? And you mentioned the model. I'm so thrilled that we have Dr. Linders on here, who has been a real long-time pediatric emergency care coordinator in Connecticut in a community hospital system that's close to our system at Yale, and took on this accountability and responsibility. And I see that our children's hospitals roles, as well as our baby and others roles, are to support these amazing men and women that work in these sometimes rural, sometimes under-resourced settings with sustainable collaboration. So the model that our baby has supported and that we've implemented leverage simulation-based experiences, which lead to some training as well as some discussion of what an ill or injured child presenting to that ED would look like or experience, but more importantly, a proactive approach to that, so that it is not waiting for that unfortunate yet predictable once every few year critically ill or injured patient, but it is actually having a series of those patients and then fostering a discussion about improvement that includes both pediatric readiness, but more importantly, a collaborative relationship, so that ED will never say, we don't do kids here, to a parent, or we don't know how to take care of children, but we'll say, we're ready and we know individuals that are out there in the community that have not only implemented these efforts, but actually sustained them for many years and demonstrated to their leadership, and more importantly, to the men, women, and children in their communities that they live near, that their ED is ready and able to take care of any ill or injured child wherever it is needed in that area. I don't know if there's any follow-on questions, Phyllis, that you had, but I did want to really flag this concept of there is no adult emergency department. Anyone working in an emergency department that cares for both children and adults wants to take care of children the best they can. The Pediatric Readiness Project is a cookbook, so to speak, for that, but applying that cookbook does take a collaboration and support, as our baby has supported some efforts, as many other states, territories, and entities across the country have done so, to support who I would say lives in every community, which is a ED clinician that's passionate about taking care of children, whether they're designated a pediatric emergency care coordinator now or they become that in the future. Every community wants the best care for the children that live there.
And I am just going to stay with you for 2 or 3 more minutes. We're waiting for Dr. McCartney anyway. And your next question was about all the simulation training. And I was hoping if you could talk about like 2 more things around this program. First of all, you always describe it to me as the checklist, before you get on an airplane. And I think that's a really interesting analogy, like making sure that that emergency room is completely prepared. And secondly, I just want to reinforce, these are proven, effective programs that are ready to go nationally. And as we heard from Dr. Remick, cost effectively, like we could, right? These are ready to go solutions as we're moving to the
Absolutely. And I heard Dr. Flyer mention legislation and some of those levers, and we'll hear from Dr. Linders in a bit, but the concept here, really, simulation is a nice foray into what I would call ongoing collaboration, where that community hospital is not seeing themselves as functioning in their own worlds, but seeing themselves as functioning in the region where there are children's hospitals and other entities that can support them in optimizing the care they provide. The simulation, as I mentioned, does provide those pediatric experiences where we're facilitating some discussions of best practices, equipment, resources, but more importantly, it is linked to improved pediatric readiness. And there are many other interventions that could be utilized for this, but in our work over a 6-month period, by leveraging simulation-based collaboration with community emergency departments nationally, we have demonstrated a 17-point improvement in pediatric readiness. And this program is really something that is a collaborative approach where really we are not doing things on that community hospital, but we are there for them to support their journey in improving pediatric readiness, and more importantly, to sustain that relationship over time. So in contrast to many trainings that are a one-off session, I firmly believe that an ongoing relationship where there is a local pediatric champion like Dr. Linders, like many of the nurses and physicians and PAs and nurse practitioners we've collaborated with, that our job that is to support them with resources and a recipe. The Pediatric Readiness Survey and Project are a wonderful cookbook for the systems-based approach. And I would say this is a companion intervention that helps to guide them through that process. And there are many other companion projects that are out there, and examples would include the National Pediatric Readiness Quality Collaborative and many others. But I want to attest to the fact that Our Baby has supported this work since its infancy, Phyllis, when we are going out and frankly actually taking the wrong approach and making EDs aware of their problems but not having the solution. So I love the fact that the second half of this discussion is going to be about solutions orientation, because the ED nurses, ED physicians that I work with in these programs are so honored to take care of children and want to do the best they can, and supporting them with resources in a sustainable way is really an imperative for us nationally.
Thank you for all of that, Dr. Arbach. I couldn't agree more with what you're saying about solutions. This has been going on for 17 years, and I'm really tired. So we're also going to get into who's accountable, how this is going to play out in the future, and how we can make this happen nationally. So I'm going to go to Dr. Camargo next, if that's okay. A couple questions, but how about we start with the development of the Find ER Now app in partnership with us, and how has this app served as a resource and addressed challenges in finding emergency care? If you'd like to start with that question.
Yeah, thank you very much, Phyllis. So Find ER Now, that's one word, is a free smartphone app that helps you find the distance, directions, and current driving times to the closest ERs anywhere in the United States. And it's based on a unique research database that our team at Mass General Hospital in Boston has developed and maintains. And we launched the Find ER Now app in 2010, but have been collaborating with Our Baby since about 2015, many years now. And thanks in part to Our Baby funding, we've surveyed all United States emergency rooms or emergency departments, ERs, EDs, annually since 2015, and have been able to add pediatric specific information to our free app. We continue to collaborate on ways to get out this information about the app and to encourage parents, caregivers, and families to have it and use it. So I'd just like to take this opportunity to encourage anyone to download the app by searching Find ER Now, that's one word, in their Apple or Google app stores. Or if you want more information about it, you could visit findernow.org, findernow.org, and that includes the download link.
Thank you for sharing that. It's been a great resource. We've gotten a lot of positive feedback from families that have used it and traveled, and has definitely helped a lot of families. So thank you for that resource. Sorry. Do you also want to, we've heard a lot about PECs today so far. Do you want to, because you've done a lot of research around that too. Do you want to talk about the importance of PECs and the role and the impact it has on the readiness?
Sure. So, some of that research has been with people on this call. So definitely want to make sure to acknowledge their contributions. As you heard, PECs manage pediatric care in the ER. They're not the ones necessarily delivering it. In fact, think of them more as coordinators who help other people rise to the occasion. And that can be through training, that can be through ensuring the right type of equipment, all the things that Dr. Remick spoke about, Dr. Auerbach spoke about, through other programs that are trying to improve care. If you go back, 2007, the National Academy of Medicine, which was known as the Institute of Medicine then, recommended that all EDs, 100%, should appoint a physician and a nurse as a PEC, as a way to improve pediatric emergency care. And multiple groups endorsed this recommendation over the years. And the sad part about this is that today still a minority of emergency departments have PECs, not even one. The data varies, but it's somewhere in the 25% range in our own work. And so again, not the 100% goal. And that's part of why we're having this call. It's a discouraging situation, but all of us around this roundtable will continue to encourage ERs without a PEC to support one or more today. And we hope that through the media, we can get out this information to the general public and perhaps get families to ask why their local ED does not have a PEC. We think that could be a big step forward.
Absolutely. And, it's like the bottom up demand, but maybe there's also something from the top that should be mandating some of these solutions for children. So we're going to get to that in a bit. But I want to move to Dr. Linders. Thank you for your patience. We've heard about this positive impact of the PECs and that you've had success and played a pivotal role. And I was hoping you could talk to that in your healthcare setting.
Sure. Thank you, Phyllis. I do have a bunch of examples that I can tell you about that we've done at our hospital healthcare system. We're a system of 3 emergency departments. One's a little bit rural, one's a little bit more inner city, and another one's more traditional shoreline. So we have a really wide variety of patients we see, and it may be about 10 to 15% of our patients are pediatric patients. But before I get into the details of some of our programs, I just want to emphasize some of the stuff that's already been said about PECs, but I do think that we're important advocates for the system of improving pediatric care in community hospitals. We're kind of like the inside people that know how to make it work within our individual institutions. I like to think of it as that we shine a light on problems, and unless you shine that light, I don't think you're going to solve it. And so that's our job, is to try to identify the problems in our department and then be developing agendas to bring to our leadership to try to get these going forward. Because as you've heard, these community hospitals have lots of other things they're seeing besides kids. 85% of what we're seeing is not pediatrics, and we have to compete with management for attention with internal medicine, surgery, psychiatric care. And so if you're not putting an agenda forward in your department, you're not going to be getting the attention on what you want to do. So I think that's a really big part of what a PEC does. Then the other part that you've also talked about is that the partnership with with the children's hospital. It's really important that is a strong relationship, because it's not a one and done. You've heard this. It's not just one simulation or one QI project. It's an ongoing process over the years. And so I thought maybe I'll tell you a story about my experience, and it really started back about 10 years ago with Dr. Auerbach. I had been my first involvement with pediatrics at a more management or leadership level was organizing the pediatric code card. That's the box that has all the equipment that we use with kids. That's complicated. It's all size based on age and weight and things like that. But I didn't like the way it was organized, so I reorganized it. And as a result of that, I kind of was like the lead person in our department with peds. We didn't have a PEC system at the time. So when a year or so later, Mark approached our hospital to do some simulation training, which was completely new for us with pediatrics. And we've all done simulation in different in medical school, through nursing school, through different certifications. But this was a very different type of simulation. It was within our own emergency department, so all 3 sites, using our own equipment and our own staff. And as that point person, I was there to observe it. And that was really the turning point for me, realizing that there's more to pediatrics than just getting the pediatric code card set up. And simulation shined a light on a lot of different things. We learned about our strengths individually but we also learned a lot about systems, problems that are completely different than just a piece of equipment or even just a training of a person. But it's that the choreography of teamwork it was something that I saw that there's going to be a lot more work to do than just making sure we have the right equipment there. So that began a 10-year process that we've worked together with EMSC and with Impacts. And I really want to shout out to you, Phyllis, and your organization, because some of our gains over the 10 years really started with your support with Impacts and Dr. Auerbach's work with us. So simulation, extremely important. It's ongoing, it needs to be ongoing, not just one time 10 years ago. Of course, many of those staff have left. So we're doing it every couple of years. We have another one coming up in a couple months. And just the year before last, I had one of our staff come to me afterwards and said, I took a job at your hospital because you do pediatric training. It makes me feel more comfortable working that I know I have somebody helping me learn more about pediatrics. And they worked at our place because of that, as opposed to another ED. So I really do think there's some employee benefit for this as well that should be emphasized. The other part that I thought simulation did was it started a buzz in the department. And like I said, it's really important to get the attention of the administration, your department. And the more you can put it in front of people, the the easier things are going to be when you ask for, I want this piece of equipment or some training. So it's contact with your management. It's that bandwidth thing, and so the PECs are the inside people. They know how to get things done. What type of process will work? So simulation gave me a lot of that. It also was very important that I developed a strong relationship with Mark, because we wanted to do this more. And rather than having his organization doing it all the time, we wanted to do it internally. And we were able to work out ways of them helping us with the things that you guys have just talked about. There's a lot of programs out there, but we may not have known about it. So it was a facilitator for us to get hooked in with that. But the other part besides simulation that I think it was important is there are other things that we were doing, and these are kind of like quality improvement projects that had a big impact on us. And as you do more projects in pediatrics, you get more comfortable with it. And it's not just me. There's a team that I work with. It's the important factors are there's 2 PECs, and it's a nurse PEC. And anybody in the healthcare industry knows if you want to get things done, you need to get nurses involved with that. They know how to get things done. And so we have 2 nurses. One is our PEC and one is our ED nurse educator. And between the 3 of us and our pediatric committee, we're able to do a lot of stuff. And you'll find as you start with pediatrics, there's a momentum, there's an enthusiasm. There's probably not a week that goes by where I have hey, I want to help you with pediatrics. I really like working with kids.
And I'm sorry to interrupt you. I have to get to the next question, but no, it's okay. It sounds like a lot of the training in your community hospital has been working, which is amazing. So it's we've heard a lot of the issues of pediatric readiness. We have solutions. I know that we've been one of the funders, but we're going to get some more solutions on how do we make this like a mandate and a nationwide system change. So I want to just make sure we are able to get to that next part. So thank you, Dr. Lindsay. I'm so glad that the solutions are working. And Dr. Nakardny, I believe, just joined, correct? I just don't see him, from the Children's Hospital of Philadelphia, from CHOP. He's on? Have everyone seen him? No? Okay. Well, while we're waiting for Dr. Nakardny, Dr. Camargo just wanted to clarify something that he had said about the app, just to make sure everyone knew how to use it for the pediatric ready portion. You're muted. He's muted. You're muted.
Thanks, Phyllis. Sorry about that. I was just going to say that the Find ER Now app has a feature which is very relevant to today's discussion, which is that families can use it to see which of their local ERs are more likely to be prepared to care for children. I mean, nothing can be guaranteed, of course, but there's a baby icon next to the EDs that have certain characteristics. And those characteristics are: one, they have a pediatric emergency care coordinator assigned. Two, they're a verified pediatric trauma center, or they're a verified pediatric burn center. Or lastly, that their entire ED is dedicated to children. And those are characteristics which we believe, I think any reasonable person would think, would help improve the quality of the pediatric emergency care. And so families who are traveling may want to look on the app to see if there are emergency rooms, emergency departments along the way that are better prepared to care for children. Likewise, you might look locally to see if your local emergency rooms have this baby icon. And if not, you might ask why they don't. Because as you're hearing from everyone on this roundtable, having a pediatric emergency care coordinator is within the grasp of everyone, every ED. And it's been a recommendation for over 15 years. And do parents and caregivers use this app? Yeah, we hear from them through their reviews of the app, through emails of gratitude for the help it's provided to them. The other group that uses the app is EMTs, emergency medical technicians who are in ambulances, basically trying with long transports to figure out where to drop off patients if something goes wrong. And so anyway, I just wanted to make sure that you all understood about the baby icon.
Thank you for that explanation. And while we're waiting for Dr. Nakarni, we're actually going to move to Dr. Flyer, who's been an extremely great vocal advocate for children and for mandatory regulation under EMSC law. Can you share why you believe going this legal route is the most effective way to ensure pediatric readiness across all emergency departments? And why haven't we seen significant changes? I know we've seen some to our existing pediatric EMS systems that have been deemed to rank the D- that Dr. Remick spoke about at the beginning.
Thank you, Phyllis. I'd be very happy to address that question. First, I just want to review for everyone. We're trying to get teams of people at the right place, at the right time, with the right help, the right people, with the right equipment and the right training. That's the system that we're trying to get. And we have not achieved that waiting for it to happen. You've just heard from all of my colleagues that we know exactly what to do to correct this situation. I alluded to the fact that in 1992, we in New Jersey were able to get the first emergency medical services for children law passed in the nation. The law stated that it was the public policy of the state that all children are entitled to comprehensive emergency medical services. Pre-hospital, that's out in the field, hospital, that's emergency department, intensive care units and wards, and rehabilitation, because if you don't have all of that in a seamless fashion, you're not going to get the outcome for that child that that child deserves. Unfortunately, that law was never implemented. Bits and pieces, perhaps, but there's no comprehensive system in New Jersey and anywhere else in the country, and perhaps nowhere else in the world, to my knowledge. So I think that I have to speak as frankly as possible to this issue. I think we know how to solve this problem, and I think we have to do the following things. We have to go to Congress, and we have to have hearings that illuminate how we failed, because all of the guardrails that should have protected children have failed to do so. The professional groups that have known about this tragedy for 30, 40 years have issued reports, but never stepped up like this and said, we have a disaster on our hands and we know how to solve it. Secondly, the hospitals of this country, when recent reporting came into the public domain about this issue, issued a statement that sort of said, you know, we're hospitals. How dare you think that we're not doing the best that can be done for children? Instead of embracing the idea that, as Dr. Remick and colleagues have shown, scientifically, we don't have what we need for children, and helping us get it. So all of that needs to be exposed, and I think Congress would be a great place to do that, because then we'll know not only who should be doing better, but we'll know how to keep it from happening in the future. The second thing that Congress needs to do, we have the word emergency in this. We need $750 million now, because with that $750 million, everything that we've talked about that works can be made real in 5,000 emergency departments at $150,000 per. And then if you take, as has been mentioned before, if you take the 30 million visits that children make to an emergency department and divide that into the $750 million, you find out that for an extra $25 a visit, we can solve the problem in our emergency department. And we can do that in a short period of time, within months to a year. The next thing Congress needs to do, Congress needs to, because this is an emergency, come up with money to help all of the first responders do the kinds of simulations and training that they need to feel comfortable taking care of children out in the field. Many kids don't make it to the emergency department because out in the field, they didn't get the care that they needed. The third thing Congress needs to do is tie emergency departments and the first responders in the field with operation centers staffed by people like Dr. Remick or Dr. Camargo or Dr. Auerbach or Dr. Linders, people who actually know how to take care of kids. And then the first responder can hold up a cell phone and just shine it on the kid. And the expert back in the operations center can help give them advice as to how to take care of that kid, because they really want to do the best job they can. And together, the team can figure out where that child should go and how. By land, by air, whatever is most appropriate, we'll have it all coordinated. It'll be a system. The last thing Congress needs to do is to make sure, as Dr. Linders and Dr. Auerbach clearly addressed, that this training and preparedness is an ongoing situation. So one of the things we can do, we can say to hospitals, if you'd really like to be paid for your work, you have to show us that in an ongoing way, you're going to be prepared for kids 24/7, 365 days a year. So the last part of this is it's got to be a federal and state partnership. We have laws that were passed in every state to make sure kids travel safely in cars. Well, every state needs to pass a law that makes a piece of the Department of Health responsible for the care of critically ill and injured kids. And when we've done all of these things, which can all be done very quickly, we will be on our way to having a system that addresses the needs of our sickest children. And I'd just like to say that I've watched this for 40 years. Our inability to create this kind of system nationwide. And there are 4 words that come to mind. It's inexcusable, it's unethical, it's immoral, and it's lethal. And we must fix this now.
Thank you, Dr. Flyer. That was very well articulated on a lot of great solutions on mandating the care for children. So I really appreciate your passion and everything you just said to help the media who's on, help us create this change that is so needed for the care of children. We have 5 more minutes of the roundtable before we get to the Q&A. So we're going to welcome Dr. Nicardini from CHOP. I didn't know if you wanted to introduce yourself, and we're going to jump into your questions, because I wanted to give you an opportunity to talk about your experience, because you get a lot of transfer patients
So if you could talk about your experience with pediatric readiness, and you also have a lot of experience with agencies, the national agencies that have done some progress, but that you agreed need to do some more. So if you can introduce yourself and speak to what we agreed on, that would be great. I think he's muted. He needs to unmute.
Well, hello, Phyllis. I hope it's not too loud. There's a lot of background noise here, but this is Vinay Nadkarni. I'm a pediatric intensivist from the Children's Hospital of Philadelphia, currently the president of the Society of Critical Care Medicine, and have served in some leadership roles in the American Heart Association and training organizations.
Great. I asked if you wouldn't mind speaking to your experience at CHOP with the pediatric readiness and what's needed, and we talked about command centers, and if you can talk about your experience and your vision and what the national agencies can be doing to support the vision.
Phyllis, I'm getting a little reverberation.
Do you have the questions that I sent you? Okay.
Yeah, I think one of the things that I can say is that many organizations like the American Academy of Pediatrics and the Society of Critical Care Medicine and the American College of Emergency Physicians, they have a lot of training materials and capability of training organizations. So sorry. Phyllis, I apologize. I'm having too much feedback to be able to speak over it.
That's okay. We can always have people follow up with you through our Q&A at the end, or even after the roundtable if you want to just stay and listen, and we can bring you in after. So we're going to go to the question and answer. I want to thank all the doctors for their insights so far. You've given so much of us to think about. We had promised at 1 o'clock we would move to question and answer. So let's see, our first question is, let's see, there's our first question.
Phyllis, this is Mark. While you're looking for that, one of the questions highlighted about pediatric pre-hospital providers and the concept of some of this work before patients come to the hospital. And I wanted to make sure that the audience was aware that there are parallel efforts and programs with pediatric emergency care coordinators and something called a pediatric pre-hospital pediatric readiness project. That perhaps Kate Remick, if you want to, I don't know if you can comment briefly more on that. That project is following the hospital-based readiness project and is a really exciting project that's really gaining a lot of momentum in this coming year.
Sure, thanks for that, Mark. Yes, in the pre-hospital setting, we know that adults account for about 90% of all pre-hospital encounters. And so there is certainly a need to increase readiness, exposure, competence related to pre-hospital pediatric emergency care. And it's particularly important because most children who are transported by EMS tend to be even more critical than children who present to emergency departments by private vehicle. And in fact, most EMS providers, pre-hospital providers, report that children create some of the greatest amounts of anxiety when it comes to managing these patients most effectively. So, as Dr. Auerbach said, there is an effort very much that mirrors the National Pediatric Readiness Project called the Pre-Hospital Pediatric Readiness Project, also based on joint recommendations from The former organizations I mentioned, as well as the National Association of EMS Physicians and the National Association of Emergency Medical Technicians. And it really outlines a systems design framework similar to pediatric readiness in the emergency department to help support these efforts. There is the first comprehensive national pre-hospital pediatric readiness assessment that will be launching actually this year in May of 2024. That's being hosted primarily through the EMS for Children program. And we're really looking forward to being able to use that for the first time to understand the pediatric capabilities of our pre-hospital emergency care system.
Thank you for that. You all are involved in a lot of projects for our children. Thank you. That sounds
Well, if I could add just one more quick thing that Dr. Camargo mentioned is that the Institute of Medicine in 2006 came out with this report on the future of emergency care. And in that report, they highlighted the importance of pediatric emergency care coordinators and EDs. But they also, at that very same time, highlighted the importance of pediatric emergency care coordinators in every EMS agency. And so this really falls on the heels of longstanding recommendations to improve care for children.
Phyllis?
Yes.
If you don't mind, I just would like to throw something out for people to consider. What I'd like them to consider is what we all lived through for the last 3 years. There was a pandemic. When it first started, I thought of my grandchildren, and I only hoped that the pandemic was not coming for them, that it was coming for older people. This country and the world has no idea what would have happened if the COVID virus had come for kids. When the virus hit and suddenly thousands of adults needed intensive care, pediatric beds were converted to adult beds. And one of my best friends, a pediatric intensive care doc, because he knew how to take care of 18-year-old people, he could transfer his knowledge and help take care of adults. And for his efforts, he got COVID and got really sick. But the point here is, if it had been the opposite, if little kids were the ones who were dying in the thousands, the mortality, the number of children that would have died because we're not prepared in many instances to take care of one really sick kid, would have been overwhelming. We could have lost the better part of a generation. And that virus is out there somewhere. And our Congress and our state politicians had better do their job and prepare our country now, within the next 6 months to a year, for that eventuality. We know how to do this.
Right. Well,
it takes the political will.
Completely agree. I think everyone on this roundtable panel is in agreement with all the issues and challenges, and we have solutions. And so now we need the government help to mandate this for it to happen. So I couldn't agree more. I'm just going to move to some other questions. Did Dr. Camargo, did you want to speak to PCARN and what you're doing to support EMS with telemedicine? Did you want to?
Yeah, so I think your question relates to this idea that Dr. Remick mentioned and Dr. Flyer mentioned, that this pre-hospital part of the emergency care continuum. And when people don't have the training, how could telehealth be used? How could you connect with them by video or even by just telephone in a way that's better than what we now have with standards and training, et cetera? And this is an area that we've done a lot of research in, specifically focused on children, but less so in the EMS, the pre-hospital arena. That is sort of in its infancy, and we have a project right now that we're working with PCOM to advance, which would bring the video camera into the pre-hospital area to, again, help people who don't necessarily have the best training in children on how to give better care. Now, part of the equation is also they need the right equipment. And this gets back to this idea of a pre-hospital tech, a pre-hospital champion who makes sure that the right equipment is there when you need it.
Yeah, so again, system-wide changes from the pre-hospital setting to the hospital setting. We need to change the system. I'm gonna take 10 seconds for the for the petition plug that we have on our website, because it actually talks about the adaptation of EMS for children. It's a really easy way for people to help out and demand change for children. So that is on ourbabyfoundation.org. I didn't have a chance to mention it earlier, but the petition can help us get to the legislators to help us mandate this change. So I'm going to go over to the next question regarding the frontline healthcare crisis we're seeing. If someone wants to address their thoughts on the significant turnover we're seeing in ERs as it relates to maintaining pediatric care quality.
Could I speak to that, Phyllis?
Okay.
Thank you. And thank you for letting me do this. I actually wanted to introduce a concept. It's called moral harm. It's when someone is trying to do their best and is unable because they don't have the support to do it that should be there. They've endured moral harm. We need to fix the system for the people who deliver the care just as much as we need to fix it for the kids who are getting the care. There's tremendous moral harm endured by people daily trying to take care of children. And if you want to know why people are burning out, this is one of the main reasons. They don't have the tools that they need to do the job they took an oath to do.
And like you said, they don't have the tools, and I just like to reiterate, they don't have the resources.
Correct.
And it's not that it's cost efficient, as you've all mentioned, $150,000 per ER to get pediatric ready. I am going to talk about another question along this realms of what are the other roadblocks to creating these national standards and regulations around pediatric readiness, and how do we overcome them? I agree. I like to hear
this is the way. We're going to let the world know this is a terrible issue. And the press is going to help us do that. And people in social media are going to help us do that. And then we'll be able to get the resources and the laws we need to make the systems the children deserve. This is it.
Yes, and I'd like to personally, there's a lot of people on this panel that have been involved in the recent research that has linked mortality to pediatric readiness. We hadn't had that data before. And again, I'm just reiterating that, if you look, you can possibly save 1,500 children a year to get our system pediatric ready. I don't know why we're not doing this yesterday. So I'm just going to keep praying that everyone listening is going to help us demand change. And I'm open to other questions that.
If I could add a comment to Peter and Tevi's in the question box about the high turnover rate. The only way to overcome this is really to think of this as a systems issue. This is not a people problem. This is not about fixing one person. And it's certainly not about training one person. It's about an overarching evolution of our systems of care to ensure that we're really integrating pediatric readiness into our organizational capacity. We've seen this actually in terms of pediatric emergency care coordinators, where many who are serving this role are serving it in a voluntary capacity. And that is most certainly not sustainable. And so it does require an ongoing commitment from these organizations to do so. And certainly there are ways to help ensure the integration of that into their overarching organizational policies.
But Phyllis, we have to think of these systems just the way we think of fire departments. No one questions the need for a fire department. And they're regulated so they can put out fires of all kinds. We need to do the exact same thing for sick kids. We do it for airlines. Nobody would get on a plane if we didn't have an FAA.
Right. I believe it's how trauma centers started. A lot of other healthcare systems.
And I believe that, nobody would take drugs if we didn't have a system to make certain that they were effective and safe. And likewise, our food supply, we have a system to make sure it's safe for us. This is just another system.
I agree.
We got to think of it as a fire department, and we have to have it, and we have to pay for it, and it has to be regulated, it has to be organized, and it just has to go forward into the future. When after this is done, people are going to wonder in 20 years, you mean you didn't have that back then?
Right. No, I completely agree, and I'm gonna shift to parents for a moment because I'm getting a lot of questions. I think we've been very clear how the media can help us really articulate this major issue, but there's been a lot of questions coming from parents, like how do they encourage hospitals to prioritize and improve their pediatric readiness? I know I mentioned the petition. Can anyone else speak to anything else that parents can be doing to help demand this change?
Yeah, I mentioned it. This is Carlos. I mentioned it in my comments, which is if people would download this free app that we create at Mass General Harvard, they could actually look at their local emergency department. And if they didn't see a baby icon, they could call and say, why don't you have a pediatric emergency care coordinator? It sounds a little aggressive, but I think you're hearing the change is needed. And the way to get that change is partly through the media. As Richard Flyer has said, it's also through legislation. I would just, Richard and I had a discussion a few months ago about his efforts in New Jersey and the 1992 legislation, which apparently supposedly fixed the problem. But Richard knows that today only 1 in 3 emergency departments have that baby icon that I was referring to earlier. How is that possible that 2 out of 3 don't? Or maybe our data aren't exactly correct. Maybe it's only half, but how is it half? I mean, this makes no sense. And yet life goes on. Does it? Not for everyone. That's the whole point of this roundtable. So whatever legislation is passed needs to have some teeth. And that's another very important part that we hope the media will cover. But for the families who are on the call, you can check to see whether your local ERs have that. You can check to see and act accordingly.
I just have to speak as a person who practiced in the community. I would wash my hands before I saw patients, and I would tell parents, if you have a life-threatening emergency, call 911. But when the truck gets there, lie down in front of the truck. Do not let them move until they promise to take you. And I mentioned the one hospital that was ready for kids. I did that with every single family, and it saved lives. But that was crazy.
Crazy.
I was the system.
Yeah, it's a tricky business because I think in New Jersey, it's a small enough state, and there are EDs that do take this issue seriously and are trying very hard to improve their pediatric emergency care or already reached a level of excellence. But in some of those big Western states where there are EDs, very few and far between, we still want to give the message to go to the nearest emergency department in the moment of crisis. But why not right now help that emergency department reach pediatric emergency care excellence in the ways that we've been talking about?
Exactly.
So it's a tricky business. You don't want to bypass an emergency department and have another extra hour of transport, which then leads to a bad outcome.
I wasn't implying that, Carlos.
No, I know that, Richard, but I just want to make that point. We've talked about this very point.
Yeah.
But in New Jersey or in urban areas, you actually do have a choice. And in those urban areas, it's not clear to me why you would go to an emergency department that doesn't seem to pay attention to these issues for children.
No.
Right. And I'm getting a lot of questions. And I learned this 17 years ago when I lost my daughter, that children's healthcare is like way underfunded versus adult healthcare. And I know that hospitals are very stressed financially, and a lot of them are losing money, and the ERs aren't fully staffed. So resources really affect these problems. So like getting up on the priority of governmental resources is key.
But Phyllis, we're the richest country in the world. And we spent $4.2 trillion on healthcare in 2021. If I ask for $1 billion to get the country ready for kids, that's I could ask for that 4,200 times for the $4.2 trillion that we spent. So it's a drop in the bucket. We just have to have the political will to make it happen.
Phyllis, I'd love to be able to comment. So I really appreciate Dr. Flyer and Carmago's and others' comments about legislation. I do want to highlight that creating a space where these community hospitals are aware of pediatric readiness as a concept and getting engaged is also a really important approach in both the short and long term. There are many solutions out there. We've talked about simulation. There's many others. And I see every time I or Kate or Bill or Dr. Flyer or Carmago gets approached to say, we want to do better about pediatric readiness, that we have many of those resources and many of them are not cost intensive. So as a family member, I think balancing going out to your local ED and saying, I don't see you in this app and you're not pediatric ready, but perhaps asking them if they're aware of the concept of pediatric readiness. And if not, we have resources that we can share with them to get engaged in that work. And again, all of these EDs have leaders as well as frontline providers who want to take optimal care for children. But unfortunately, with the low frequency of these critical events, many times they don't address these gaps until it's reactive, till a child dies or has a bad outcome. So I see a real important role for parents speaking for their children, just like we do on many other things, and saying, are you pediatric ready? Are you aware of pediatric readiness? If not, get engaged. And I really think that that is a approach that a parent can leverage their knowledge of their own community, either not being engaged and get them engaged, or being engaged and having low readiness, and garner the support of the leadership of their hospital to access and use the resources that we have, and that this isn't asking that hospital to spend hundreds of millions of dollars, even tens of thousands of dollars on day one. It's about getting engaged. Also want to say that all of those other levers are absolutely critical that Rich and other mentioned, but I think that from a parent perspective, calling that local ED or talking to someone that's involved in that local hospital to find out about their role in pediatric readiness is a step that I think any parent can take within their community.
Thank you for that. I
want on that, Mark. Any community organizations that want to take this on to help their hospital get ready. I mean, we have all these service organizations. They're wonderful. They don't know that we need to do this. Many of them could be absolutely instrumental. They were instrumental in getting our law passed.
Which is a great segue to, because someone brought up the legislation of the Rory Staunton. Sorry, I'm mispronouncing his name. I think everyone's aware of his unfortunate death with the with sepsis, and how that that legislation made all the difference for national care around sepsis. Does anyone want to speak to that? Because, you know, we have like tons of questions coming in, and like, how can the media help? And this is one way that they helped that piece of legislation move and make system changes around sepsis. Does anyone want to speak to that?
I just think that it's a wonderful part of creating a total system that will address all of the medical, surgical, and psychiatric issues that affect kids. Sepsis is a big problem. Specific legislation to address sepsis is a great accomplishment, but it doesn't address all of the other critically ill.
Right. Well, that was an example of how the media helped.
Right. Obviously they did. And now the media have to help us get everything, the whole system.
So what is the one thing, and Dr. Linders, I haven't heard from you, if you want to jump in, is there one thing that you wish that the media or the public better understood about pediatric readiness?
Sure.
Again, we want them to be our advocates. And I just want to, we've talked a lot about advocacy, and I know there's cost efficiency, but we still do need resources. So we're going to get to that.
Well, as the inside guy in a community hospital, and as I alluded to before, there's competing concerns. And one of those concerns that I didn't allude to earlier is the staffing problem. Staffing is a huge problem in all the emergency departments, and some more so than others. Many emergency departments are running understaffed. They know they should have more people, but they literally don't have enough eligible people that want to work there or can work there. So this staffing is huge. The other part of that is a lot of hospitals aren't doing so well financially. The pandemic hit a lot of them financially. There was some compensation that helped them, but that's waned as the pandemic waned, and many of them are doing really poorly. So I don't know the numbers, but I'd be curious to know how readiness in pediatrics correlates with financial viability. But if you have a hospital struggling to put staff in their department, and they're having trouble with paying really high prices for nurses that are we call travel nurses that are coming from different areas of the country to help out, but their training in pediatrics may be very variable. A number of community hospitals are solving their staffing problems with maybe undertrained people. So the finances can't be ignored in trying to solve this problem. And a lot of that is a very complicated, really outside of my range. But I can tell you that I've had problems with training being delayed because we don't have enough staff right now to focus on that. We need to fill shifts, and we can't dedicate time right now. So it's affected me, and our hospital does very well. But I feel for hospitals in different parts of the community where they're very much struggling. If they may not even be, some of them are closing. So to take the bandwidth to focus on pediatric readiness when you don't know if you're going to be open in a year or two, if you don't have enough staff, and the staff are overworked and are leaving because of that. So there's some real life issues that on the inside is competing with all we want to do good about readiness.
Right. So thank you for that. Children are dying in the process of us not being pediatric ready. So I just want to reiterate that point. I'm getting questions. There's so many questions, but like one is like, how do we get the simulation training into hospitals? And obviously, Dr. Arbach leads that initiative. But you can speak to that better than me. But again, I believe it should be a nationally mandated continuation of pediatric training readiness in ERs. So maybe you want to, we're getting questions on that as well.
Yeah, so thank you, Phyllis, for that question. So really, through our collaboration over 10 plus years now, we have shifted from, as I mentioned before, doing this out in community EDs and requiring really expensive equipment to having off-the-shelf solutions where we're working collaboratively with those community sites. And I will flag that there are states in our country that are working on legislation now that are going to require things like quarterly pediatric simulations to ensure ongoing pediatric training and readiness. I want to flag that there are state level initiatives and national initiatives, and that state level initiatives are another area that individuals might be able to get engaged. And I wanted to see if maybe I could pass the baton to Dr. Remick on that, related to her great knowledge about the state and federal sort of interplay there.
Yeah, I mean, there's funding to every state and U.S. territory to be able to integrate the needs of children into emergency care systems. That's funded through the EMS for Children program. And for those who are looking for what activities are on the docket at their state level, they can look up their state EMS for Children state partnership program and identify a number of activities with which they can engage, resources, networking, and the like. So it's really a nice way of helping to identify the work that's being done on the front lines. And just also to add to that there are now 18 states that are in the process of developing pediatric readiness recognition programs, that have gone live. And there are many, many more that have this work underway.
Okay, I'm going to start wrapping it up because there's so many questions. I want to make sure everyone's aware
that were willing to take questions as the roundtable ends. I am so grateful for everyone's participation, attendance. We're so grateful. I think what we do next is where the change is going to actually happen. Again, if we can possibly save 1,500 children a year to get pediatric ready nationwide, it's cost effective, it's proven solutions. I'm sorry if I sound repetitive, but we can do this. We just need people's help for advocacy and resources. And, please look on our website for the petition and for other ways to help. And together we can make change. Together we can save lives. And I am so sorry we didn't get to the 30 other questions, but we will address them after the roundtable. One by one, we are all equally passionate and are here to continue to answer questions as the roundtable is ending. So thank you to all the panelists and all the participants, and
thank you.
make change.
Thank you.
Thank you.
Thank you.